My name is Dr. Tim Brown, and I will be talking to you today about insomnia management and the pitfalls associated with the drugs. As you can see from my bio, I am the Director of Interprofessional Education for the University of Georgia's College of Pharmacy and also a professor at Augusta University UGA's Partnership in Athens, Georgia. I have no disclosures to make here with regard to the medications in our discussion today. The objectives of the talk that we're going to be looking at really deal with the diagnostic criteria of insomnia. We're also going to talk about the medications in general, but I really want to talk about their pitfalls and what the evidence-based medicine is showing us about their use. Spend a bit of time on non-pharmacologic approaches because it is the backbone or the mainstay of management. Then also talk a bit about treatment goals, patient education, and what we look at clinically with regard to insomnia. Insomnia is one of the most common complaints you hear in a medical office. It is widely apparent that in the last year, stress has increased even more so, and so insomnia has become almost a daily occurrence with regard to people talking about lack of sleep, stress, and worry. It's very prevalent in women, and as we age, it also becomes more apparent. In addition to that, they see it much more with psychiatric illness. About 50% of the cases discussed with insomnia usually are associated with some background in dealing with psychiatry or mental health. Also, it can have a role when it deals with societal stressors, such as poverty, dealing with losing a job, or working and worrying about how ends are going to meet when it comes to finances and life in general. Symptoms may wax and wane. I think it's important to realize that insomnia may not happen all at once. In other words, it may not be persistent for 6 months. It may come in spurts, quite frankly, based on what's causing it and what's going on. So it's not that it has to occur necessarily for a given period of time, but we'll talk about the definition in just a moment of what persistent insomnia looks like. Please realize that when you're looking at patients and what's going on, that 1 in 5 have discussed using some sort of medication to help them sleep in the evening, about 20%. It's a large number when you stop and think about it. So it's important that you look at the background of the patient and who you're dealing with and what's going on when it comes to insomnia, because it could be a symptom of what's happening in their lives at the time. Now, I mentioned insomnia as a symptom. Honestly, that's probably not fair. Insomnia can exist all on its own. It does not have to have a mental health background or a stressor going on. You simply could have insomnia. So it's important that we treat each patient individually and not group them into one area. But it is important that we know how to define insomnia. And so when you look at the DSM-5, it really talks about the quantity and quality of sleep. And there's 3 aspects to insomnia. First is difficulty falling asleep or initiating. The second is maintaining or staying asleep through the evening. And the third is wakening in the early morning hours, so not getting a full night's rest even though you know you should or your body is telling you to. If this occurs greater than 3 nights per week and is present for about 3 months or 90 days, it is considered to be persistent insomnia. So as I mentioned earlier, this might happen during a time of the year where things are particularly stressful. Think about folks that have maybe lost a loved one in the past, and as the anniversary of that date comes around. The holidays may be a great example. And for others, it may be a change. So when we talk about seasonal change, children going back to school, those kinds of aspects. So once again, it can wax and wane with the symptoms. Please keep in mind that insomnia can occur, as I've mentioned, without it being due to something. But one of the areas I really want to address in a moment is the things that can actually precipitate or cause insomnia. When you look at the different disease states that are out there, many of them can impact and cause insomnia. Because of that, I want you really to take a look at the boxes and note some of the areas that you should rule out. One of the bigger ones that we talk a great deal about is obstructive sleep apnea, OSA. Is this playing a significant role here? What's the body habitus of your patient? If you can usually use a CPAP or BiPAP, you may take care of the insomnia by taking care of the OSA. That's an example of knowing the underlying cause that could actually take a significant problem the patient's undergoing and get rid of it by taking care of 2 situations at one time with one remedy. Substance abuse withdrawal. Again, over the past year, we've seen a large number of people drinking more and possibly even using narcotics and other medicines to a higher degree. If they're trying to withdraw as things are sort of normalizing in their life, they're going to work now and leaving the house 5 days a week, then you may see issues with sleep there. Also, please keep in mind anything dealing with incontinence, having to urinate frequently over the evening can cause people to be up all times of the night and not maintaining their sleep. Then Other things you'd look for, blood sugars, thyroid, doing lab testing. So it's important that you sort of go through a checkbox and get a really great history of what the patient's going through, either past medical or current situations that are happening. So, first question of the day. What is the first step in the management of insomnia disorder? A, recommend an OTC sedating antihistamine. B, prescribe trazodone. C, perform a medication review. D, recommend increasing exercise. Or E, prescribing a low-dose non-benzodiazepine receptor agonist. I'll give you a moment to answer that question. In this situation, you really want to look at a medication review first. The reason for this is medications in general should not be given for insomnia until non-pharmacologic avenues have been taken before. So looking at A, B, and E, those would not be a great choice here. You'd want to hold off on medications. D, increasing exercise, if you do it near bedtime, is actually not a great answer. What you want to do is look at a medication review first. As we talked about with disease state management, if you can look at the medications, there's a possibility there could be an underlying problem with what they're taking. If you look at the boxes here, you'll see there's a host of different drugs that can play a role with sleep disorder. Don't forget looking at herbals and OTCs as well. When you're doing a medication review or a medication history, it's not just the prescription drugs. Someone could be using, for example, bitter orange. You also have to delve a bit into their personal use of illicit products. If they're using stimulants, if they're using anything like cocaine, then you could have a problem when it comes to sleep as well. Obviously, the problem is deeper than sleep when you talk about illicit substances, but at least we give you an idea of where the sleep pattern disturbance is coming from. Also note other aspects that are kind of commonplace, for example, corticosteroids, even albuterol use. How often are they using their rescue inhaler? And then please keep in mind that anytime you deal with over-the-counter medications, for example, decongestants, they can have a stimulating effect as well. Once you rule out medications and underlying issues with terms of disease states, what you want to do is then look at assessment scales. There are no labs that predict insomnia. There are no labs that tell you, yes, this is insomnia. So the objective measures we use are actually things that deal with rating scales. And this is one of the most common ones. The Epworth Sleepiness Scale, you'll see it mentioned many times, not only for insomnia, but you'll see it in cataplexy, you'll see it in narcolepsy. This is the scale that many people use in the clinical trials to ascertain if a product actually has an impact on sleep. So this scale can be used with regard to the patient so they get an idea of exactly where they fit and what's going on, and also give you more background on the complaint of insomnia. To take it one step further, since we can't see our patients 24/7, it's important they do a sleep diary so you have an idea of exactly what's going on, how they're impacted. The rating scales are listed here for this sleep diary as well. So these are two objective measures that can come in the door. So once you've realized that it's not a medication or an underlying disease state, then you do these scales. One of the other things is, what if it is a medication, an underlying disease state, and you take care of both of those? One, by changing the medication, or two, by taking care of the underlying problem, and they still have insomnia. These scales are the next step to sort of see what's going on, to delve a bit deeper. Once insomnia has been diagnosed, persistent in particular, you're looking at how do you manage it. Every guideline that's in the literature talks about non-pharmacologic therapy. It's one of the backbones when it comes to dealing with insomnia. CBT-I, cognitive behavioral therapy for insomnia, is probably one of the most common things that you will see when it comes to the discussion of management. It involves a host of different aspects, everything from sleep hygiene all the way down to sleep restriction therapy. And we're going to talk about each of these. But please keep in mind that this is the go-to when someone's first discussing insomnia. It's not to start a medication or add a medication immediately. It's really to look at the non-pharmacologic approach, especially if you think this is going to be persistent or chronic insomnia. CBTI has a host of a lot of different aspects. One of the key things that comes to mind is sleep hygiene. Many people already know about this simply because we talk about it a great deal. One of the things we know is we should use the bedroom for sleep and for sex, only in those activities. We should not be lying in bed watching TV. Also, how we eat and what we eat. Avoiding caffeine directly after lunch, avoiding naps, maintaining a quiet and dark room is also helpful. So in looking over these make common sense, and these are probably the things that we're the most familiar with. Sleep hygiene. I think a lot of us have probably even used this ourselves when we're dealing with our sleep issues. But CBTI also goes into a deeper stance. Relaxation training is one of the key areas that people talk about. It's everything from meditation to hypnosis, progressive muscle relaxation. These are tips and trends that can be taught to someone non-pharmacologically. Probably not from a pharmacist perspective, but working with one of our interprofessional partners, this is something that can be looked at with regard to insomnia management. When you talk about relaxation training, this is not done solo. When I talk about each of the CBTIs, they are done together or in concert, so it's not necessarily one modality over another. That brings us to stimulus control. This is that whole thing that we talked about earlier under sleep hygiene. If you look at stimulus control, it goes back to sleep hygiene, some of the components. Dark, quiet room, taking pets and children out of your bedroom, decreasing distractions, ambient light. I think many people still use their smartphones these days for their alarm clock. Should they? Should they have a different type of mode of alarm in the morning to wake them up? That way they don't have the ambient light from their electronic devices shining on them in the evening. Also keep in mind that when you deal with sleeping and intimacy or sex for the bedroom, everything else leaves the bedroom and is done in other rooms. If you can't fall asleep, you get up, do something, and come back to bed. So it's not forcing yourself to lay there in that bed without sleeping. CBTI also has cognitive therapy, and this is really talking about that aspect of changing the way we believe things. So, for example, I can't fall asleep unless I have a drink. I can't go to sleep unless I take that Benadryl. I really just should stay in bed. I need to rest. I just can't sleep. I just need to lay here and rest. Those are things that take a bit more time than the other aspects. But probably the one that takes the most time is called sleep restriction therapy. It actually is the goal of decreasing the time that you actually sleep, resetting your sleep cycle, and making your body exhausted, quite frankly, so eventually you find a pattern that sort of promotes sleep. It sounds pretty harsh, but studies have shown that this is probably one of the most accurate non-pharmacologic aspects that can be taken in managing insomnia. But it does take a diligent, resourceful patient for this to occur and a plan. It takes about several weeks, anywhere from 3 to 5, for this to become effective. So this is not a 3-day thing. This is actually a month to a month and a half of dealing with sleep restriction therapy to reset the sleep pattern and promote sleep to get over the insomnia. Not something easily done, but once again, if it is done, it has been shown to be effective. That brings us to the pharmacy aspect of the talk. Pharmacologic management for insomnia is probably one of the easiest things people snap to. Let's take a drug that makes us sleepy. I've listed the different drugs classes there for you. We're going to walk through each of these, but I really want to make it clear. I'm not here to talk about efficacy. I know that each one of these drugs will make you tired. It's the after effect or the side effects or the pitfalls that I think we should focus on to discuss. Are any of them safer than another? We know they'll put you to sleep, but aren't there side effects that come with that or problems? So in looking at pharmacologic management, the majority of drugs that are out there deal with some sort of chemical change, whether it be histamine or GABA or dealing with dopamine. It actually changes the way our brain looks at sleep and the way the chemicals move in and around our brain. The problem, of course, with that is that sometimes when you're dealing with those kinds of aspects, there can be dependence or this aspect where once you start taking it, it's hard to stop taking it. And that is a problematic aspect when you realize insomnia should not be treated long-term with medications. Really short-term is what we're looking for. And I'll talk about that when we get near the pitfalls area. So when we talk about the different aspects of the pharmacologic, they're listed there for you and how they work in the brain. Let's talk about in general also about warnings. We have to worry about hypersensitivity when it comes to several of these medications, so be careful with anaphylaxis and angioedema. Also, the neuropsychiatric effects. There are studies that talk about suicide rates increasing, depression increasing, also people having abnormal or bizarre behavior. And we're going to talk about those in the pitfalls as well and what evidence-based medicine is showing us. Then also complex sleep-related behaviors. So some things that may happen when they're not fully awake, almost as though they have amnesia for the events, like sleep driving, eating, gambling, those things that we've heard about in the literature that do exist. These are general hypnotic warnings and pitfalls, particularly associated with the Z drugs. And we'll talk about that class as well. But the Z drugs are the ones that people talk in terms about getting up in the middle of the night, opening the fridge, and eating a sandwich, and then having no recollection of the fact that you were up in the middle of the night eating. Things that kind of get scary, especially if someone leaves their home, gets in a car, or is found wandering their neighborhood. So, to start with medications, let's start with the granddaddy of sleep meds, benzodiazepines. They've been around for quite some time, as you know. In the 1980s, they were used a great deal for anxiety, but over time, we realized that their use long-term was not optimal. Matter of fact, it led to a great deal of dependence. We now do not see a really great time to use benzodiazepines chronically, especially when it comes to insomnia. However, I put them in this mix because we still need to review them and look at them in terms of what the literature talks about. One of the key things about benzodiazepines is they are Schedule 4s, and they can cause everything from hypnosis to amnesia, and they're also can be used as anxiolytic. As many know, we also use these as anticonvulsants, and you'll even see them being used for alcohol withdrawal in a managed environment such as an inpatient hospital or a detox center. Side effects are listed there for you. Next day sedation and impairment. We've talked about incoordination and falls. The difficulty with this product is, once again, it does make you tired. That's the whole purpose. But because of that, there are side effects when it comes to mentation as well as dexterity. So that leads me to my next question. Which of the following benzodiazepines is the most likely to cause next day sedation? A, flurazepam. B, azepam. C, temazepam. D, triazolam. Or E, none of the above. I'll give you guys just a moment to look through those. The answer here is B, and the reason is the drug half-life. While the benzodiazepines share the same mechanism of action in terms of how they work to make you sleep, and also a broad case of indications, they actually have their own kinetic profiles that make them different. So there are long-acting, intermediate, and short-acting. And when it deals with a drug with a longer half-life, when you wake up in the morning, that drug is still on board, as all of us know. Well, the chance for someone to actually increase the fall risk, have mentation issues, drive while impaired because they still have a benzodiazepine in their system could cause problems. The half-life of this particular product, answer B, is 190 hours in the elderly. So you can imagine how much difficulty it would be to clear this particular product if you were older, but also how much more difficult it would be if you had liver issues as well. So an overview of kinetics are listed here for you. I want to draw your attention to temazepam. Temazepam is an intermittent acting. You can see that it's actually conjugation only when it comes to metabolism. Many folks felt that benzodiazepines were not a good choice for insomnia, but if you were going to use one, temazepam at 7.5 milligrams was probably the best one to use, especially for the elderly population. I'll leave that there with you, but you can see the half-life and what happens with that. I would still maintain that benzodiazepines are probably not where I would go as a first-line pharmacologic choice for insomnia because of the addiction potential or dependence and because of what we're seeing in terms of drug interactions with regard to narcotics. Well, that brings us to the new and improved benzodiazepines, if you will. I know these are not benzodiazepines. Matter of fact, they're called non-benzodiazepines, but they still work at GABA. And I think many people felt that these drugs would actually be a safer alternative to benzodiazepines. And in some situations, that assumption is probably true, but they also come with their own issues as well. The ones listed here are usually considered to be called Z drugs. And you can see that they're Schedule 4s as well, and they're more selective for the GABA area than the benzodiazepines. They cause amnesia and also a hypnosedative effect we talked about, but if you'll notice, the side effects are very similar to the benzodiazepines that are listed there for you. However, there's less potential for rebound insomnia. There's less potential for tolerance and dependence than we saw with benzodiazepines as well. Now, that's how it went through the FDA. In clinical practice, I think many would tell you that there is a dependence issue with Z drugs as well. Is it as great as benzodiazepines? I'm not sure one could say that that's true or false based on the clinical trials that are out there. There's no great data except for the data generated by the makers of the Z drugs at this point. I did the same thing here. I wrote down the kinetics for you, put them in place for all the Z drugs that are listed so you would know. Pay special attention to zolpidem and realize the dose does decrease for women, and it's because of the metabolism is slowed in women, leading to an increased level or AUC that can cause side effects. My point here is please be aware of the birth sex of your patient. If you have a transgender patient, you need to know what their birth sex is so you can actually make the correct dosing adjustment, since liver does not necessarily change with metabolism in transgender patients. You would still want to make sure that you use their birth gender for dosing. The whole meat and potatoes of the CE program is discussing the pitfalls and the issues in using the medications. With the background I've just given you, I'd like to go back and talk about the evidence-based medicine of some of the hypnotics of benzodiazepines and the Z drugs. When you look at the data, most of the data is not really geared towards efficacy, as I mentioned earlier. It's geared much more to safety, side effects, those problems. So what I did was I went through and looked for evidence-based medicine and trials to talk about the pitfalls or things that are more common. I tried my best to say to things that had good outcome measures, but also were rational. It wasn't a correlation. It was actually a discussion where it looked at some way that these do impact or touch. And one of the first studies that came about was the Hordaland study. The Hordaland study actually happened in Norway. And what they did was this study linked the Norwegian cause of death registry, looking at the number of people who passed away using a hypnotic in their medication profile. And what they found is that there was a twofold risk of mortality when they looked at their death registry compared to people who were not on hypnotics in Norway. So they linked this together. When you looked at this, the Hordaland trial was about 13 to 15 years of data looking at the death registry over that period of time. When they put this together, they also saw that the hypnotic mortality rate was almost comparable to cigarette smoking, which is amazing when you think about that. So the same number of people who died being on a hypnotic looks similar to the number of people who had died secondary to cigarette use. So that estimates the deaths to be 300 to 500,000 deaths per year are associated with hypnotic use. Not something you hear very often, but something that we now know as the opioid epidemic has ramped up, that many of the folks that we see that overdose also have a benzodiazepine on board. That doesn't necessarily mean that it's the benzodiazepine that caused the death or the overdose, but we know it increased the risk. Falls and fractures. There were 20 studies looking at this over time. It was a pooled relative increase of 24 to 58% of benzodiazepine users had hip fractures. Many of these products did not have Z drugs put into their data. It looked more at benzodiazepines. Overall, however, there was a 13 to 30% increased risk of fracture, also attributable to benzodiazepines as well. Then there was a meta-analysis of 9 studies that reported a pooled estimate of 92% risk of fractures with zolpidem. That is the only one I could find that dealt with the Z drugs. So a 92% excess risk with a Z drug called zolpidem. And you can see that the other was 24 to 58 for benzodiazepines for a hip fracture, but also the risk of fracture overall with benzodiazepines was about 30%. Motor vehicle accidents. Strong causal relationship between the use of hypnotics and MVAs. Matter of fact, data found that high blood levels and impaired driving, despite being fully awake, led to many of these accidents. Remember, we talked a great deal about the hangover effect, or the drug still being around the next morning. People basically driving with slower reflexes or slower mentation because they have a benzodiazepine on board. FDA cautions all people taking CR products from the Z drug category should not be driving the next day and operate heavy machinery. Drug overdose. I've talked about this a couple of times, but here is kind of the statistics. 75% of overdoses with benzodiazepines also involve an opioid. So imagine the number of people that are actually using these two classes together and the overdose rate that we're seeing. Obviously, the reversal agents are different for these. So sometimes the reversal agent for the narcotic can be given quickly, but many people do not realize that benzodiazepine has been given, and several people do not realize there is an antidote for benzo reversal, or taking the benzo away from the receptors. Infection rate. Meta-analysis noted 44% higher infection rate versus placebo, but overall the causal relationship was really not established in the literature. There was a higher incidence of pneumonia in those that used hypnotics, and the question is that due to aspiration? Is it due because obviously it makes you sleepy, tired, you lay down, and you can aspirate? But really, truthfully, they were unsure of why this happened. Strep pneumo is one of the major bugs that they saw in the mix of this, but the data is much more scarce when it comes to infections, in particular looking at infections dealing with the lungs. Depression. In the beginning of this discussion, I talked about the fact that there's a generalized warning when it comes to hypnotics. Depression has been increased at least 2.1 times newly diagnosed with those that are on hypnotics. The question is, however, are we diagnosing correctly or looking at the products and patients as a whole? In bipolar disease, many people present with depression, and folks do not realize there's an anxiety component as well. By giving a benzodiazepine, have we then treated the anxiety component and increased the depression, and that's why we're seeing it? Who knows? But it looks as though you're sort of taking one side of the seesaw and pushing it down while the other goes up. That may be the reason that we're seeing depression here. It could be also the reason that benzodiazepines and Z-drugs are also depressant products. Associated with high rates of suicide overall, 4.2 versus non-users, but no causality has been found, but it was there in terms of odds ratio. And also a possible link with a history of bipolar. As I mentioned, insomnia is associated many times with a psychiatric diagnosis or mental illness. And so looking at that background and deciding what to use is important, but also trying to use other products to take care of the mental illness or the diagnosis could help with the insomnia without using benzodiazepines or Z-drugs. And then overprescribing. Zolpidem is the most prescribed hypnotic in the U.S. 68% of Zolpidem patients were sustained users. 68% sustained users. Large group of people also using opioids in this as well. Over 1/3 of office visits that result in prescriptions for hypnotics do not show any documentation whatsoever for insomnia. So in other words, we're giving out benzos and Z drugs and this drug and that drug, but the chart doesn't really say this person has persistent insomnia secondary to this or with no underlying cause. There's really no discussion about that aspect to it. Also, as we talked about earlier, is it sleep apnea, which to me seems is one of the most simple things to look at in terms of a sleep study and also with BiPAP, CPAP management. There's an estimate that 75% of hypnotic prescriptions are without a valid indication overall. Matter of fact, in 2013, there were 40 million scripts dealing with hypnotics. Greater than 77% of those patients had 2 safety contraindications or more associated with why they should not be on a hypnotic. For example, they have a history of depression, they have a history of alcohol, substance abuse. So, and remember, 1 in 5 are on a med from our statistics earlier, about 20% of the population. The orexin receptor antagonists are a newer class. There are 2 drugs now in this class, Belsomra and Dayvigo. They're class 4 as well when it comes to controlled substances. They're newer, as I mentioned, so the literature is not as robust. They block orexin A and B neuropeptides, and basically this leads to helping with sleep quality. And it's much better for sleep maintenance, these products are. They're okay for sleep onset, but usually with sleep onset, you need a much higher dose. They're much better for the maintenance of the sleep. They also have a strong 3A4 interaction when it comes to those medications, and you can see the side effects listed there for you. These are a bit more expensive than the hypnotics we've talked about to this point. Belsomra is about $14 a dose, and Dayvigo is about $11 a dose. The clinical trials are not the best of quality here in looking at these. There was some publication bias noted for Belsomra especially, but what we do know is if anyone uses these products, they need at least a 7-hour window of sleep. So when they wake up refreshed, there's no hangover effect, or they're not dealing with the next day residual effects of taking this particular products. So 7-hour window is what's required. Melatonin receptor agonist. Rosarum is probably the one we all know here, even though they're over-the-counter melatonin products. Rosarum is the prescription. It's a much more affinity for the MT receptors. There are very little side effects associated with melatonin and almost no daytime sleepiness whatsoever. There's weak evidence that it does help with sleep onset, but really no evidence whatsoever for maintenance. So it's not as strong, if you will, as the products we've talked already, but the maximal effect may take up to 3 weeks. So that's something that many people do not want to deal with. However, as people age, melatonin does decrease. So if you're talking an older person dealing with insomnia and you've ruled out other causes for the insomnia, this may be a place to start versus using something that's a C4 and talking about the drugs that we had before. This might be something that could be started and worked with and titrated up for the patient. Sedating antidepressants. The only time really you should be looking at antidepressants when it comes to sedation is if there is a comorbid of depression. Some of the drugs listed here, the first one I have listed is doxepin. Doxepin and Evidencebased are TCAs, and they can be used. Doxepin, however, does have an indication for insomnia. It's better for sleep maintenance, lower side effects. However, notice at the top I've talked about anticholinergic effects. It's important to realize there was an observational trial that came out of the UK that discussed exposure to anticholinergic effects could lead to increased chance of dementia later in life. This was particularly true for people over the age of 40. So using a product long-term with anticholinergic side effects may be detrimental not just because of the current side effects that one sees, but long-term impact overall. You can see the dosing that's listed there for you for doxepin. I would tell you that Elavil is probably not the best choice to be using because it does have a high incidence of anticholinergic side effects, and certainly you must have caution when it comes to folks with BPH, urinary retention, or any kind of GI abnormalities such as constipation or IBS. Mirtazapine or Remeron is the one that I think many people think of when it comes to sleep for an older population when it comes to having depression and insomnia. As a matter of fact, guidelines talk about the fact that if there's a comorbid condition such as depression, then antidepressants would become first-line therapy in managing the insomnia if drugs were where the practitioner wanted to go versus non-pharmacologic therapy failing and moving beyond that. Remeron itself actually also helps people with eating. It does give them more of an appetite. So if you have an elderly person that's failure to thrive and having sleep issues, Remeron low dose may be a place to start with regard to taking care of several of the diseases that are going on or several of the symptoms the patient is experiencing. Trazodone or Desiril is something that you see used quite frequently. And honestly, it has no data really to back up its being efficacious. One of the aspects in dealing with Trazodone is that it is actually used because it's not a controlled substance. However, data has shown that it is not the best to use overall when it comes to antidepressants. Sedating antihistamines are probably some of the ones that we see people use the most because they can be bought OTC or without a prescription. Benadryl or diphenhydramine is the most apparent one that you see in many of the OTC products talking about insomnia or sleep difficulties. These are H1 receptor antagonists, as we know. There's very limited data with their use in insomnia. The key thing here is anticholinergic side effects, but also dosing. You'd want to use the lowest dose possible, so looking at anywhere 25 to 50 milligrams, but you could even talk about a 6.25 to 12.5 milligram dose for someone that might not need a full 25 to 50 milligrams. Unisom is another OTC product that you may see as well. Once again, antihistamines in general should not be used long-term, especially for insomnia. We also deal, once again, with the fact that you're dealing with anticholinergics, so BPH, urinary retention, and of course constipation or irritable bowel syndrome with constipation could be a problem if these are used. Herbal medications. As I mentioned earlier, it's important in a medication history to also talk about herbal products. Melatonin, valerian, and kava kava are three that have been talked about for insomnia for quite some time. Melatonin, we've already talked about rosarum being a better choice because of the affinity. Valerian root actually is really well studied in Europe. However, the trials are not that great overall. Particularly, you'll see this used in Germany as a tea. It is not recommended any longer because of hepatotoxicity and pancreatitis, so it is not one of those products that we think about recommending for insomnia management. And then kava kava is much like alcohol in the way it works. South Pacific Islanders actually use this much the way we do alcohol. It does have hepatotoxicity associated with it, and some say it can cause problems with regard to dependence. It is not recommended either. So the key takeaways from our discussion today really is talking about how we can look at the considerations for those that are complaining or they have a problem sleeping. For example, let's look at alcohol use, nicotine use, illicit drug use, and see if those play a role here. If people are drinking too much caffeine, for example, can we turn that around for them? Also looking at medication-induced insomnia. Are there things that we've actually caused by giving them a medication to take care of another problem that's led to the insomnia? Overall, what you're trying to do is find some semblance of a balance so people can actually have good quality and quantity of sleep, but also they can function the next day. They can do what they meant to do either with their job, their families, their responsibilities. Then the other discussion comes is once you start managing insomnia with medications, when do you stop? And honestly, when you look at data, it doesn't go beyond 12 months. Long-term treatment of insomnia is not something the literature talks about or really talks about doing in terms of guidelines. Medication should be discontinued after about 4 to 5 weeks. So only about a month on a medication. That's not what we're seeing in practice. However, it is what the recommendation is. If medications are going to be used, please realize that patient preference and individuality is important. What's the sex of the patient? What are they complaining of? Is it onset, maintenance, or waking up early? How often does it occur? Is there a stressor in their life? What's happened in the past when things have gotten better and they're able to sleep, if this has been a waxing and waning situation? Also, how does it look overall for the patient? Is this happening during a certain period of time where it actually ends within a week? Is it something that goes on for 3 months? Can you find a way that that goes in their sleep diary and actually works with something that's happening in their life? Can you look at that, change it, move about it? And also, it takes more than just one person to manage a patient. So the interprofessional team should be talking here. This shouldn't just be about drugs. This should also have some therapy associated with it, mental health counselors, as well as other folks to look at the entire patient holistically, not just about insomnia as one sort of a one-trick pony. Also, your general approach here is non-pharm, non-pharm, non-pharm. And before you go to medications, you really want that team looking at this patient to see if there's anything that's been missed before you commit this person to using any of the products. The pitfalls are quite large, and there's really just no great benefit from the drugs overall long-term. So getting to drugs or to medications, you have to have a plan that it's only going to be used for a short period of time and off. It's better if you never start and you find the rationale or the reason for the insomnia and medications are not used. I say all that tongue-in-cheek because, quite frankly, there are barriers. We all need our sleep, quality of life, next day issues, working, taking care of our families. That's all things that we have to work with. However, pharmacologically, there's really nothing on the market that I'll call safe without problems. There are many pitfalls associated with the medications we've talked about today. Also, one of the things that we really don't talk about enough is when patients actually come in for their annual visits and things that are going on, in a medication review, that discussion of why are you on this? What's going on? Did it get better? Did it get worse? Really something that can't be done many times in a 15-minute provider-based visit. This has to be done over multiple visits with multiple practitioners, and it can be done in different settings, from community pharmacies to mental health offices to seeing their primary care provider and a family medicine or internal medicine clinic. This is all something that can be asked and worked together as a team when it comes to trying to find out why someone's using, for example, a Z drug, without just giving it to them because they've had it for the last 2 years. Also, please keep in mind that anticholinergic side effects, the over-the-counter medications we've talked about, and some of the antidepressants could actually have an adverse effect later in life, especially for patients over the age of 40. The additive effects could cause an increased chance of dementia happening as we age. So for clinical summary, I put together just a little bit to sort of sum up what we talked about. This particular table talks about each of the products that we've talked and discussed, and also how they fit with regard to the 3 different areas when it comes to insomnia. Just for your review, the next slide is a clinical summary with an algorithm of how you should look at your patients and what you should be looking at. The next slide are the guidelines, and I will tell you here you can also add the Veterans Association or the VA. They actually have guidelines that just launched in 2020 into 2021. They mirror a lot of what you're seeing here. They do recommend CBTI as their first-line therapy. So talking to your patient, if you have a patient who's discussing insomnia and what should they do, and you're trying to counsel them through it, and medications have been decided to be an option for this particular patient, here are some ideas or thoughts you should be having in your mind as a pharmacist to talk with your patients. Make sure they're taking the medications close to bedtime, and only if they have can able to devote a full night's sleep. In other words, that's 7 to 8 hours. Otherwise, the residual effects may happen if they're waking up earlier or have to be up earlier because of commitments. One of the key things is next day impairment. Please have them take this medication where the next day they can have an idea of how much it impacted them, but did not impact what they were doing with their routine. So, for example, if they have Saturday and Sunday off, maybe taking their first dose on a Friday night so they can see how it really impacts them for the weekend, not necessarily on one of the days where they have a lot of responsibilities and they have to be up for it. Also, let them know that this is a common occurrence and they should be looking out for it, because driving, taking care of children, or making any kind of big decisions could be impacted by the medication they took the night before. Taking these with meals or immediately after meals sometimes can slow their absorption, so that may not be the best thing to do to get the full impact of the dose. And they should not be used with alcohol or other CNS depressants, including, of course, narcotics or opioids. They can develop tolerance or dependence and require more to help them sleep each night. If this is occurring, they need to speak with someone about this immediately. Self-escalation of dosing is not where this needs to go. As a matter of fact, we should be doing a de-escalation of dosing if we talk about the fact that the medication should be ending in 4 to 5 weeks. Also, please keep in mind I've talked about the complex aspects when it comes to neuropsychiatry, the overeating or the getting up in the middle of the night to eat, driving, not realizing that you've driven somewhere, walking outside your home almost as though you're sleepwalking. So please keep in mind that people need to hear this, know this, and be in a safe environment with someone around them when they take these medications. That way they have someone to watch over them, so if these side effects do occur, they can be noted and found by a family member or a close member on especially the first few nights that they're using the medication. Then we've also talked about hypersensitivity reactions overall in dealing with anaphylaxis. I hope you've enjoyed this discussion today on insomnia. I hope we've talked about the literature and brought some things to light. But I also hope you have a broader understanding of how to manage patients with insomnia, that it's not a simple, let's give a medication and that will take care of everything. Thank you once again. My name is Dr. Tim Brown, and I appreciate you listening to this.